A very warm and cheerful good morning to everyone. I am delighted to welcome you all to day 5 of the International Expert Talk Series 2025, which is centered on the theme Shaping Tomorrow's Pharmacists, International Best Practices and Emerging Trends, organized by Department of Pharmacy Practice and Pharmacology, Excel College of Pharmacy. Today's expert talks in the topic Responsibilities in Medication Management of Healthcare. This session is designed to emphasize the critical responsibilities of healthcare professionals in the ensuring safe, effective, and rational medication use, which increasing therapeutic complexities and patient diversity. The role of healthcare professionals in medication management is more important than ever. By actively monitoring, educating, and collaborating, they can help prevent medication errors, enhance adherence, and improve patient outcomes. With this, now I have the honor of inviting Mrs. M. Aruna, Organization Secretary, to deliver the welcome address. Please, ma'am.
Thank you, Bala. Hello, everyone. Good morning and welcome to our webinar on Shaping Tomorrow's Pharmacist, International Best Practices and Emerging Trends, organized by Department of Pharmacy Practice and Pharmacology. Thank you so much for taking the time out of your day to join us. Let's welcome all the delegates and participants present here. We are also very excited to have Mrs. Srimul Gangadharan. Welcome, ma'am. Registered Intensive Care Nurse UAE with us today, who will be sharing their insights on responsibilities in medication management healthcare professional. Feel free to join us. Thank you, ma'am.
Thank you so much for your warm invitation.
Thank you, ma'am. Now I invite Mr. Bhagawan, Department of Pharmacology, to introduce our eminent speaker, Mr. Srimul Gangadharan, NMC Royal Hospital, United Arab Emirates, who will be delivering today's expert talk. Please, sir.
Good morning, everyone. It gives me great pleasure to introduce today's distinguished expert speaker in our International Expert Talk Series, Day 5, Mrs. Srimul Gangadharan, Madam. Mrs. Srimul Gangadharan is a highly accomplished registered nurse and intensive care specialist with an impressive career spanning more than 15 years across India and the UAE. She is currently associated with NMC Royal Hospital Sharjah, where she plays a vital leadership role in supervising ICU and HDU teams. Under her guidance, these units are setting benchmarks in critical care excellence, patient safety, and evidence-based nursing practices. Her professional journey reflects dedication and deep expertise in critical care nursing. She has served in leadership roles at reputed institutions including Manipal Hospitals, Narayana Medical College, and BIMS Hospitals. Her clinical expertise is wide-ranging, covering cardiac ICU, kidney transplant units, and emergency response. Beyond her clinical skills, she is well-trained and certified in internationally recognized programs such as Basic Life Support, Advanced Cardiac Life Support, and Pediatric Advanced Life Support. Additionally, she has advanced training in critical care procedures and telemetry monitoring, infection control, and biomedical equipment handling, making her an all-rounder in intensive care. She is truly an inspiration for healthcare professionals, embodying the principles of dedication, compassion, and excellence in patient care. With this brief introduction, let us warmly welcome our esteemed speaker, Mrs. Srimul Gangadharan, Madam, to share her expertise and insights with us today. Thank you.
So, responsibilities of healthcare professionals in medication management. This presentation will guide you through the comprehensive landscape of medication management, covering crucial responsibilities from safe preparation and dispensing to advanced topics like narcotic policy, antibiotic stewardship. We will explore each aspect in detail, ensuring the holistic understanding of how healthcare professionals collaborate to achieve patient safety and optimal healthcare outcomes. So, medication management encompasses a complete system designed to ensure every patient receives the correct medication at the right dose, through the right route, at the right time, and for a right indication. This involves a continuous interdisciplinary process from prescribing and dispensing to administration and monitoring. The ultimate goal is to optimize individual patient outcomes, prevent medication errors, and minimize adverse drug events, thereby safeguarding patient well-being and enhancing overall healthcare quality. So we are going to the safe preparation and dispensing. So safe preparation and dispensing are the cornerstones of medication management. This phase involves meticulous attention to detail to ensure the correct dose, correct dose form and quantity are prepared and given to the patient. Key procedures include triple checking the prescription against the product, verifying patient information, and ensuring the medications is correctly labeled with clear and understandable instructions. Any deviations, no matter how small, can lead to significant patient harm. So in different hospitals, they are following the different policies. Like actually we are following in the when the doctor is prescribing, the doctor only transcribing also. So the medication order will go to the pharmacy. The clinical pharmacist will follow that according to the patient weight, according to the patient allergy condition history and everything. The patient initially they will check with the doctor order. So then they will, if there is any dose variation, they will contact the doctors again. Then they will change the doses. Again, the nurse has to indent the product, the medications. Then only the pharmacy will dispense. In some of the hospitals, again, the indenting is not by the nurses. It's again by the doctors only. But in India I think it is again with the nurses only. But in GCC countries, the indenting process also by the doctors only. So the medication preparation will be done by the pharmacist in the pharmacy. In some institution, again the preparation of medications will be done by the nurses. So medication preparation and dispensing is the cornerstone of medication. So the first one, the doctor will prescribe the medication. The clinical pharmacist will be the follow the order. So according to the patient needs and condition, and they will make sure it is appropriate to the patient. Then they will dispense the medications to the administration area. Then going to the LASA, that is look-alike, sound-alike medications. Look-alike, sound-alike medications are leading cause of medication error. Are you agree with this? Anyone? Are you agree the look-alike, sound-alike medications are leading cause of medication error? Am I audible?
Yes, ma'am, audible, ma'am.
Okay. Are you agreeing this with this? Look-alike, sound-alike medications are the leading cause of medication errors? Okay. To prevent such errors, pharmacists must be exceptionally vigilant. Strategies including using Tolman lettering labels, segregating LASA drugs on shelves, and implementing mandatory barcode scanning and double checks during the dispensing process. Patient counseling is also crucial, as patient can help verify the medication they are receiving based on the appearance or intended use. Again, look-alike, sound-alike medication, we have to segregate in the special cupboard, in the separate cupboard, and we have to label. In many hospitals, usually we are labeling with the yellow color sticker, LASA stickers, and the LASA cupboard should have the separate key. The one of the pharmacy, even in the pharmacy or in the nursing areas, the separate staff should have the LASA cupboard keys, and it should be labeled in the Tolman letter. And implementing barcode scanning also should be there, and whenever we are using, the double check should be there. Though if one of the nurse is going to administer the LASA look-alike, sound-alike drug, then the other RN should have a look on that. So they should, she should confirm with the next RN, that is registered nurse. She has to confirm this medication is going to give the patient. So according to, first initially she has to verify the patient order, patient name, patient MRN number, then medical record number, then the order should be placed in the system or in the case file. So according to that, the both RNs has to go and take the medications. They have to confirm, then only they can administer the LASA drugs. And patient counseling is also crucial. The patient counseling can be done by either at the pharmacist or in a staff nurse or a doctor, because with in the OP basis, pharmacists are giving the medications for the patients, and in IP, while discharging, the nurses are handing over the discharge medications to the patient. So both the ways, either the pharmacist or the nurse has to give the counseling or education to the patient if they are on look-alike, sound-alike medications. Coming to the narcotic policy, this is a strict duty of care. The management of narcotics and other controlled substances is governed by strict federal and state regulations. So as we know, the Minister of Health is very strict on dispensing narcotic drugs and administration also. Pharmacists have a legal and ethical responsibility to prevent diversion and misuse. So whenever in the pharmacy, as we know, the pharmacist, there will be a narcotics pharmacist separately for the narcotic drugs and control and semi-control drugs. The same way, the nurses also, the separate registered nurse will be handling the narcotics in the IP areas, and this involves inventory management, secure storage in the locked safe, meticulous record keeping for every dose dispensed, and through verification of prescriptions from authorized prescribers. So whenever we are getting the medication order from the doctor, we should, without any documented order, so in the e-order, electronic order, or in the file, we should confirm that the order is placed by the doctors. We should not give any narcotics, any medicines we cannot give unless it is in the code blue or an emergency situation. But in case of narcotics, semi-control and control drugs, we should not, at any cost, we should not give medications. The registration nurse or the pharmacist have rights to defend it to the doctors that first you give the order, then I can give the medications. So we have right to defense in that. In India, I think it's we can give the medication in the verbal order, but in GCC countries we cannot give any medications in the verbal order, especially the narcotics. We don't have any policy to give that medication, narcotics or control drugs in the upon the verbal orders. So we are not giving any medications. So if we want to give a medication, narcotic drugs, we should have a proper administering order in the system. And this we have this NPCM, that is it is connected to the Ministry of Health. If we are giving the narcotic drugs to the patient, it will go directly reflect in the NPCM. So the doctor order, first initially he will put in the order in the NPCM portal. The Ministry of, this is the portal under the Ministry of Health of UAE. So this each and every prescription will go to the portal. Then from there, the nurse can see the orders. She should confirm before giving, before opening each and every ampule or even a tablet. So she has to confirm the order. She will confirm. Then when she got a confirmation order, then she will go to the medication. She will check with the other RN. Then they will dispense the medication, administer the medication to the patients. Nurses' responsibilities in the narcotic policy. The storage and security is the first one, that is ensuring narcotics are stored in a locked double lock cupboard, automated dispensing cabinet. So make sure the narcotics are stored in a locked cupboard. So locked cupboard, it will be stainless steel cupboard with double keys, double door, and keys or access codes should kept only by authorized staff, usually charge nurse or duty nurse. So in the IP areas like ICU, theatre, operation theatre, PICU, NICU, these kind of areas only we will have the narcotic drugs or the control or semi-control cabinet. So always the two nurses will carry the keys. The first key will be with the in-charge nurse and the second key will be with the team leader. So both the keys will be carried by the two persons. So we should not leave the narcotics keys unattended. We cannot give, we should carry this to, same like ID band, ID card we have to carry with 2 nurses. Then the documentation, record all narcotics in the controlled drug register, hard copy and electronic. Yes, again the documentation, whenever each shift, entry of the shift and each entry of the, we have 2 shifts here. So in the morning and in the evening, the team leader will check each and every ampule with date, manufacturing date, expiry and strength, dose, everything will be checked by the team leader. So each entry must include date, time, patient name and ID, drug name, strength. Actually, the checking documentation is again 2 types. One is patient based and other one is ward stock. Ward stock twice we are checking, and patient wise, whenever we are using the to the patient, then and there we have to document it with date and time, patient name, drug name, strength, dose, prescriber order, remaining balance in the stock. This is a format for the documentation, and 2 nurses must be signed in this. So the receipt now, even in the portal also they have, we have the option that is a witness signature. So once we are the first nurse, whoever is administering the medication, they will sign in the system, and again they will give forward to the witness. So once the witness is again clarify and everything, whoever is physically witness for the medication administration, she will give the electronic witness also. She will accept the order and accept the first nurse sign, then only it is valid. So in that we have how much mg we are giving to the patient, how much we are giving, how much we are discarding, and everything will be included in that with date and time. Then the administration. So administration, again, first thing is we have to identify the, we have to we should check for the orders. First one is checking prescription only. The validity prescription should be the 24 hours only. Once the doctor is prescribing the narcotics, within 24 hours we have to give it. Otherwise, if it is not after 24 hours, automatically it will not be valid. It will disable in the system. Again, we have to get the other order. If there is an order and we are not going to administer the patient with, we should write the reason why we are not giving the medication, then we can cancel the order. Within 24 hours we should do this. Again, prescription is there. Then verify the right patient. How will you verify the patient? Code number. Okay, simple thing. This is IPSG goal number 1, that is International Patient Safety Goal. Number 1 is identification. Identification must be there before giving the medications. Okay, so you have identified the patient, then going to the drug. So order is there in the system. So you can look into that, the right dose, right drug, right route and right time. Then you are administering the medications, right? Then obtain co-signature from the other nurse. This is actually nurse's responsibility. Even the pharmacy also doing this, the same thing only. While dispensing the narcotic drugs, there the second pharmacist will be there. They will confirm with them only. Then only they are giving the medication. And the narcotic drugs and control drugs, they are not sending with the porters or with the housekeeping or with the and other persons. Only the registered nurse has to go to the pharmacy. They will receive the medication. The team leader or in charge will go to the pharmacy. Then they will receive the medication from the pharmacy, directly from the pharmacist, narcotic pharmacist. Then they will keep in the department. So after administration, the nurse will co-signature from the other nurse when preparing and administering narcotics. So the witness should be there. Administer immediately after preparation, never pre-prepare. Okay. If some doctors are telling the nurses that we will have the intubation, electric intubation for the patient, if the nurse can prepare the control medications or narcotic medication early? No, she should not. So whenever they are going to intubate, just before 2-3 minutes only she can open the narcotic cupboard. That too she should confirm she got the prescription from the doctors. After that she can open the cabinet, she can load the medication and give to the doctor. Then waste disposable. Waste and disposable is again is a part of narcotic dose is unused. So half vial of, suppose for example, half vial of morphine or pethidine or fentanyl we are giving to the patient, and half dose 50, the 100 mg fentanyl is there, we are giving only the 50 mg of fentanyl. So the rest 50 we should, the who is administering nurse, she has to discard the 50 mg of fentanyl in the running water in the presence of other nurse. The witness should be there for the disposal also. So that is also a vital role. So why we are using this? To prevent the misuse of narcotics. Somewhere, some of the actually nowadays every hospital employees or whoever is there, they are aware of this narcotics, they are aware of the consequences of narcotics drugs, but still some places again it is happening. To prevent that consequences, the disposal should be done in front of a nurse, or the second registered nurse should be there in front of the nurse only. The first nurse can discard the medication, that too into the running water, and record the wastage in the register with 2 signature. So again, while giving of medication also 2 signature should be there. Even in the wastage of registration also 2 signature should be there. Expired or damaged narcotics are returned to the pharmacy following the policy. Again, the expired medications we are not keeping the till expired date. We are not keeping any drugs in the like IP areas like theater or ICU. So short expiry date, in some of the hospitals the short expiry drugs will be returned to the pharmacy within 3 months, or some hospitals we are returning the medication to the within 1 month, or in some hospitals we are returning the medications within 6 months. So that is depends on the policy of the hospital. Anyway, the till expiry date we are not going to keep any of the medications in the hospital, in the IP areas, and damaged narcotics are returned to the pharmacy. So if while handling, the damage should not be there, because whenever you are receiving the medicines, the RN is registered nurse is going to the pharmacy and receiving the medication. So she has to observe whether the ampule, each ampule she has to observe, and she has to put high alert label on that. Then only she can receive the ampules. So in some case, we all are human, we can have a mistake. So unexpectedly one ampule is broken, or something is happened like that, immediately this should be raised to the line manager, and line manager will be informed to the pharmacy. So handover, again the handover in every shift change, the narcotics shock must be counted by 2 nurses. Again, the witness should be there, outgoing and incoming nurses will be there. They have to change, they have to check each and ampule with, because every day we are restocking the medication, batch number will be separate, doses will be separate. So every day, each shift, the team leader will again count the medication, she will record it, record in the e-record or in the manual record. So discrepancies must be reported immediately to the nurse manager and pharmacy. Same again, if you are finding some discrepancies going on there in the department, then immediately the nurse will inform to the line manager and pharmacy. Reporting and incident management. Report any discrepancy, missing orders or suspected diversion immediately. Follow hospital incident reporting system. So in every incident, in every hospital we will have an incident reporting system. It can be a paper, or it can be electronic again. So whenever it happened, if it happened immediately, then and there we have to report in the portal, or we have to report to the quality of pharmacy, wherever the other authority, to the authority we have to inform. Never attempt to hide or adjust records to fix errors. Yes, so never attempt to hide these discrepancies. We should not hide or adjust records, because when, if it is going to the legally, not only the narcotic, not only the control medication, each and every medications, we should have our proper documentation and proper information. Crystal clear information should be there, because if it is going legally, after many years, we might forget it, but after many years again these legal cases will come to you, then you will not talk, your document will talk that time. So the documentation should be very clear and we should not hide it. Okay, that's all about the narcotic drugs. So going to the fridge medications process. First of all, fridge medication process, selection of refrigerator. Use a dedicated medical refrigerator. So whenever you are selecting a refrigerator to stock, to keep the medications, we should make sure that there should not be, there will not be any food or drink in the medication fridge. Should have temperature monitoring system 2 to 8 degree. The medication temperature, medication fridge temperature is 2 degrees Celsius to 8 degrees Celsius, and temperature monitoring should be there. Maintain fridge temperature between 2 degree to 8 degrees Celsius. Place a calibrator, thermometer or digital data logger inside. Yes. So as per the policy or as per the JCI protocol, the digital data logger should be placed in the fridge. If there is any temperature variation, the digital data logger will give us alarm, then we have to act immediately. Record temperature twice daily or use automatic monitoring. Again, in the pharmacy, if even in the pharmacy or in the IP areas, if the medication temperature, medication fridge is there, the concerned staff should check the temperature twice a daily, and we have to monitor, and we should have the record on that. Immediate checklist. We are using the checklist for the fridge temperature and freezer temperature, every room temperature, everything. We have the separate checklist, and every twice a day we are checking also. Immediate action if temperature is out of range. So immediate action if the temperature is out of range, what we will do? We will inform. If it is in the IP areas, immediate first thing is we should recheck. So data logger is giving the alarm, the temperature is not within the range, that is 2 to 8, temperature is not within the range, then immediately we have to recheck it, because sometimes door is not closed properly, or data logger is not kept properly. In that cases also temperature variations can be there. So immediate action is recheck. What is the, find out the causes. So because of what cause the temperature variation is there. Then what should you do? In IP cases, we have to, if really the temperature is out of range, immediately we have to inform the line manager and inform the pharmacy. So get the cold chain back from the pharmacy, and with the medication data log sheet and the cold chain bag, we have to return all the medication to the pharmacy, and immediately we should inform to the biomed for the checking of the fridge temperature. So either they can replace with the other fridge, or they can manage. If it is a manageable thing, they can manage. So once it is ready, we should confirm that the temperature is in the range, that is 2 to 8 degrees Celsius. Then the pharmacist, the department line manager, the biomed people, the 3 people will be confirming and verifying the fridge. Then after that, again pharmacy will dispense the medications to the IP areas. So storage practices, again, do not store medicines in the door, because whenever we are opening the door, the temperature fluctuations will be there for that medication. So we should not keep any fridge medications in the door. Place medicines in the middle shelves for stable cooling. This is again this protocol that we should keep medications in the middle shelves only. The bottom or upper cabinet, we are not keeping the medications. Keep medicines inside original packing. Yes, again, we should not remove any original packing of the patient. Protects from the light and mix up. Maintain separations. Yes, we have, if we have many medications like vaccines, insulins, eye drops, or any antibiotics, certain antibiotics also we are keeping in the fridge. So if we have this kind of medications, then we should keep it separately. Vaccines in the one place, insulin should be in one place, eye drops should be in the one place. Like that we have to keep the medications. No food, drinks or lab samples. Again, it is very, very important. In the fridge medications, there should not be any food, drink or lab sample. Lab sample also we cannot keep in the fridge medication. And there should be a label on top of, on the fridge, that is no beverages. Label should be pasted on the fridge. Labeling and organization. Label medications with name, date of opening, if required. That is again multi-dose vials. If we are doing using insulin vials or Xylocard, Xylokin, like that, if we are using a NDG vials, nitroglycerin vials, these and all multi-dose vial, that multi-dose also except insulin, all will be discarded within 24 hours. But insulin we can keep up to 28 days. So again, the date of opening should be there and date of expiry also. From the date of opening, 28 days will be the expiry date of insulin vials. Arrange using first empty, first expiry, first out system. Yes. So we have to keep the first expiry medications in the first out system. That means we are using the near expiry drugs in the early. Handling during use. Minimize the door opening. Take out of medication just before administration. Never leave fridge medications inside, outside unnecessarily. So minimize door opening. The fridge medications without any reasons, we should not open unnecessarily, and take out of medication just before administration. So first, prior to the administration, we have to check when we want to, if to suppose we have to give the medication by 10 o'clock, then just before 5 or 10 minutes we have to take the medication and dilute it. We should administer the medication. Never leave fridge medications outside unnecessarily. So we are getting the IP areas, we are getting the fridge medications from the pharmacy with ice packs or a cold chain box. So we immediately after receiving these medicines, we should keep in the fridge. We should not keep in the normal storage area. Then power failure breakdown plan. If power goes, keep fridge closed to preserve cooling. Have an emergency backup plan, generator backup, cooler box with ice pack, transfer to another monitored fridge, document incident and take an action. The same thing. So fridge is out of range, then immediately we have to inform. We should get the call chain back from the pharmacy. We have to return the medicine to the pharmacy and document incident and actions taken. The follow-up should be there. Then documentation, temperature log sheet should be there. That is again checklist, temperature, freezer temperature, fridge temperature, all documentation log sheet should be there. Inventory record, stock received, used, discarded. Again, fridge medication should have the separate inventory records. So it will not be included in the floor stock medications. The fridge medication document, medication record, inventory records will be the different. Incident reports. If any excursions happen. Okay, incident reports. If again anything happen, then we have to raise the incident. Examples of fridge medications are vaccines, insulin, certain eye or ear drops, some antibiotics, biological and chemotherapy agents. So these are the examples of fridge medications. Then coming to the appropriate checking. The appropriate checking, it's a final safeguard. So we all know that we are saving, we all are working as a team for the patient safe only. So this is one of the most important element before giving the medications to the patient, that is appropriate checking of medications. If the nurse is giving a medication from the ward stock, okay, not from the pharmacy, at a start dose, the nurse is giving a medication from the ward stock, then she should check this appropriate checkness. That is, the elements of full appropriateness review is the appropriateness of full drug dose, frequency and route of administration. First thing, the appropriateness, according to the doctor's order, she should check dose, route, frequency and route of administration. Then therapeutic duplication, she should check the therapeutic duplication, that is for the same indication we are giving the 2 drugs. So therapeutic duplication should not be there. That also we have to confirm. If she has any doubt, anytime she can call the clinical pharmacist, either clinical pharmacist, or she can contact the prescriber doctor. Then real or potential allergies or sensitives. Okay, whenever we are getting the patient to the IP area or in the OP, the consultant doctor should update their allergies in the file. So allergy should be there in the file. If there is no allergy for no patient, then they have to mention not known. So if there is any potential allergy, if the patient is having fever and she is allergic to the paracetamol, but unknowingly doctor is prescribed the paracetamol drugs for the patient, then the nurse, while doing this appropriateness of review of medication, the nurse can find that patient is having allergic to the paracetamol. Then she should raise this issue to the doctor and he will prescribe the alternative drugs. So appropriateness should be there. Then a reel of potential interaction between the medication and other medication or food. So reel of potential interaction between the medication and other medication. Actually, we have a link, Medscape link we are using. In that we can give 2 drugs, and giving of the doctor is prescribing 2 drugs for the patient, aspirin and Codron for the patient, and we don't know whether there is any interactions or contraindications for these 2 drugs. So we can enter these 2 drugs in that. So in the Medscape link, then the system will give these drugs can be given or not. So that is real potential interaction should be find out. So the interaction between the medication and food will be done by the dietitian, not by the nurse or not by the pharmacist, not by the doctors. This food and drug interaction will be done by the, between medication and food interaction will be done by the dietitian only. These 4 will be done by the nurses if she is using a ward stock medication. Then 5th, 6th and 7th and 8th points will be done by the clinical pharmacist. Variation from hospital criteria for use, then patient weight and other physiological information. Okay, again the patient height and weight should be recorded in the patient file. That is the IP, even in the OP or clinic time or in the IP, the patient weight and height will be recorded. So according to that, the clinical pharmacist can follow the medication doses. The current or potential impact as indicated by laboratory values. Again, if the patient is getting antibiotic, first initial days they will start the antibiotic. After 2-3 days, again the culture comes. The clinical pharmacist will review the laboratory values. Then the antibiotic resistant or If it is okay for the patient, then he will continue, or it is resistant, he will advise the doctor to change the prescription according to the culture report. Same like the patient is having hypokalemia, hyperkalemia. The patient is on potassium syrup. For long days, patient is on potassium syrup, and patient potassium value is more than the normal. That is, patient is in the hyperkalemia according to today's report. So every morning in the rounds, doctor's rounds, we are doing the multidisciplinary rounds that includes the doctor, nurses, clinical pharmacist, dietitian, physiotherapist, and speech therapist will be there. So in the rounds, multidisciplinary team rounds, the clinical pharmacist will follow all the patient lab values and medication dose, medication according to the dose, weight, route, everything he will be individually he will be doing for all critical care patients. Not only all critical care patients, all IP patients, he is confirming the medications according to the lab reports and patient needs. Then current or potential impact as indicated, other contraindications. So contraindications also checked by the clinical pharmacist only. Okay, again, coming to the medication reconciliation. So this is a bridge the gaps in the care. So like if you are getting a patient to the getting admitted to the IP, so we should do the medication reconciliation. That is, medication reconciliation is a formal process of creating the most accurate list possible of all medication a patient is taking. This is especially vital during transition of care, such as hospital admission, transfer, or discharge. The pharmacist plays a key role in collecting a comprehensive medication history, including prescription drugs, over-the-counter medication, and supplements. The process helps to prevent omissions, duplications, and harmful drug interactions. So, example, one patient is getting admitted to the ICU. So, the doctor will collect the history from the patient or from the relative. If he is on any medication, regular medications, and the patient is admitting with some other disease condition, but patient is already known case of diabetic or hypertension or thyroid, she or he has some comorbidities, and patient is admitting with some other disease condition like vomiting, diarrhea, or something else, then these drugs should not be missed. So the doctor or clinical pharmacist will collect the history from the patient, either from the patient or from the relative. Then they have to start these medications according to the patient needs. So this is especially vital during transition of care, such as hospital hospital admission or transfer or discharge. So in this case, either clinical pharmacists can do it or the doctors can do it. And in this case, one more thing is there, then patient is having on drug medications. If they are taking, for example, he is taking some Concor tablet. Concor tablet he is taking from long time, and when he admit, he has a stock of 30 drugs and 30 tablets he has, and he is not an insurance patient, self-paying patient. Then the nurse will, the reconciliation will be done. Again, the nurse, what she will do, she will receive this medication in front of another staff. Then we have a medication verification form. So she will inform the doctor that the patient has only 30 tablets with this. So you can put the order in the system, so I can send this medication for the verification to the pharmacy. So after getting an order in the system, she will be sending this medication with medication verification form to the pharmacy. The pharmacist will verify the medication according to the order and date, expiry, manufacturing date, again all the allergics, everything she will verify. Then she will put a on medication sticker, and she will send it back to the IP area. So in IP areas, again, we are not going to give this medication to the patient. We will administer this medication while discharge or transfer out. If transfer out, we will give this medication to the another department nurse, and while discharging, the leftover medication will be given to the patient. That is the process. Coming to the ANDT. So ANDT is aseptic non-touch technique, that is comes under the administrating of medication, maintaining a sterile environment. Aseptic non-touch technique is a practice used to prevent contamination during sterile procedure, such as preparing intravenous medications or compounding sterile products. The core principle is to avoid touching key parts of sterile equipment and product itself. This requires meticulous hand hygiene, use of sterile gloves, and handling materials in designated sterile field. ANDT is a fundamental skill of hospital and compounding pharmacists to ensure the safety of injectable. Again, some of the hospital, the injectable items are diluting and preparing by the pharmacist. They will ready to use will be given to the department. From the pharmacy, the medication will be diluted and given to the IP areas. But in some hospitals or some institution, they will give the medication as it is, and the staff nurses will be diluting and giving according to the order. That is depend on the hospital policy. Anyway, whoever is doing this procedure, they should follow the aseptic non-touch technique. So first, the guidelines of aseptic non-touch technique is, first one is clean hands. Use alcohol hand rub or soap and water. So we have to, hand hygiene is it's a key. Actually, it's a key of key to prevent the infections. So first and main thing is clean hands. Either we can do a hand rub or we can do the hand wash with soap and water. Then clean tray, use a large plastic or metal tray, wipe with the disinfectant. So each and every preparation of medication, before each and every preparation of medications, we should wipe the tray with disinfectant, allow surface to dry before use. So there will be the contact time for the disinfectant. So allow this contact time. Some of the wipes will have disinfectant contact time is 1 minute, or some will be 2 minutes, some will be 3 minutes. So according to the manufacturing recommendation, we should give the timing for the disinfectant agent. Then once it is done, then gather the equipment, place all necessary equipment around the tray within reach. Then clean hands. After cleaning of this tray and cleaning gather equipment, again the hand hygiene is very, very important. Apply non-sterile gloves. No need to wear sterile gloves while preparing the medications. We can have the clean gloves also. Perform without touching key parts. So ANDT techniques, again, while opening the syringes, the tip of the needle should not touch anywhere. And preparing IV infusions, protecting key parts using non-touch technique, disinfect ampule neck while rubber cork with ampule swab for 15 seconds. So after opening of a vial, the rubber cork with alcohol swab for 15 minutes. Again, we are practicing this. Let it dry for 30 seconds, that dilute the medication appropriately. So after cleaning and disinfection only, we can do the medication dilution. The scrub key parts, have scrub for 30 seconds. Allow it dry for 30 seconds. The key parts hub is Q sites. Q sites we are using, that is the end of the cannula. We are using a Q site, that is a one-way valve. The blood will not come out, but we can administer medication through the Q sites. So the blood any blood loss or any cannula problem will not be there. So that Q site we have to clean the scrub with 30 seconds alcohol swabs. Then only we can allow. This will be done by the nurses, not by the pharmacist. But the preparation either can be done by the pharmacist or can be done by the nurses. Administer the drug using NTT, non-touch technique. So NTT is non-touch technique. Administer infusion medication using non-touch technique. Ensure all key parts are protected. Again, key parts that the needle should not be touched anywhere. Only the rubber cork and syringes. Syringe should not keep in the tray, not in the floor or not in the table. Anywhere we cannot keep the syringes. With the disinfected tray only we can keep the syringes under. Dispose of sharp and equipment. So place the sharp into a dedicated sharp bin at point of use. Okay, and again sharp bin will be available in every patient rooms. As per the protocol and policy of the hospital, sharp bin should be kept in the every patient room. So whenever we are using the sharps like needles or any other sharps, then and there we have to, whoever is using, the same person, either it's a doctor or a nurse or a technician, whoever it, they have to discard the sharp items. That is the policy. Then dispose the glove and hand wash and document. Again, after dispose of all the gloves, all waste and everything, hand wash and documentation. Again, your document will be more important. After giving of medication, the documentation should be proper. Coming to the recall of medication, immediate response to flow. The medication recalls are issued when the drug is found to be defective, contaminated or pose a health risk. Pharmacists are the first line of defense the managing a recall. Their responsibilities include quickly identifying and quarantining all affected products, notifying patients who have received the recalled medication and ensuring the product is returned to the manufacturer. A swift or organized response is essential to remove the dangerous product from the supply chain and protect patient safety. Again, the medication recall is the process that is will be done by the pharmacist. If they have found any defective or contaminated drug, then immediately they have to recall all the batch, the same batch medication wherever they dispatched, even the IP, even in the discharged patients, or from the OP you are giving to the OP patients. Whoever got this medication, immediately they have to contact that persons and they have to recall the medications. Otherwise it will be harmful or the dangerous situations will occur, and immediately they have to inform to the manufacturer also. So the vital role is the role will be playing by the pharmacist only. Next one is antibiotic stewardship. So antibiotic stewardship is a critical public health responsibility aimed to promoting the appropriate use of antibiotics to prevent their effectiveness. Pharmacists play a central role by reviewing antibiotic prescription, ensuring the correct dose, route, drug and duration of therapy are used. They also educate the prescribers and patients on the dangers of antibiotic resistance by advocating or judicious use. Pharmacists contribute to campaigning this global threat. So the antibiotic stewardship program, whenever the patient is getting admitted to the hospital, the doctor will prescribe the antibiotic. So before administering of antibiotic, mostly we are sending the cultures, all cultures for the patient, like sputum culture, urine culture, blood culture, everything we are sending. So for the 3 days the dose will be given to the patients. So according to the patient condition, if there is any fever or any sepsis, like symptoms like sepsis, the 3 days, up to 3 days, this antibiotic will be continued. On the 3rd day, once the culture report comes, the clinical pharmacist will review this. Clinical pharmacist as well as the doctors will review the antibiotic. The initial day, after sending of initial antibiotic form only, the pharmacy will dispense the medications. After 72 hours, both the clinical pharmacist and doctor will review the culture report. According to the culture report, they will decide whether they have to escalate the medications or they can de-escalate the medication, de-escalate the antibiotic dose. If they want to continue, again the doctor has to send the antibiotic form. Sorry. Again the doctor has to continue the he has to send the antibiotic form to the pharmacy. Again they will verify and they will dispense the medication to the IP areas. This is antibiotic stewardship. This is main goal is to prevent the antibiotic resistance. Okay, coming to the medication error management, the path to continue quality improvement, that is when the medication error is occurs, the responsibility management is crucial for improving patient safety system. This involves not only reporting the error but also conducting through root cause analysis and understand why it happened. The focus is on identifying systematic weakness rather than blaming individuals. Pharmacists are integral to process, helping to implement new protocols, update technology, or provide additional training to prevent similar errors in the future. Okay. Medication errors, if it happen, either it can be dispensing error, administrating error, transcribing error, or prescribing error, whatever it may be. So we are not going to judge anyone. We are not going to corner anyone. So we should find out why it happened. So what was the problem? Why it happened? Then focus on that. Then we have to obviously the incident will be raised. So according to the incident report, we have to go through the root cause analysis to find out the reason why it happened. Once it is find out, either we can give the counseling or we can do the take the actions accordingly. So if it is sometimes administration error can happen. Maybe the nurse will be very busy, or the manpower shortage will be there, or she is not knowledge on she doesn't have knowledge on that medication, and some busy schedule, the patient BP is lower side, like normal BP only, or he is going to hypertension, but actually that patient is hypertensive patient and there is regular medication. The nurse is going without checking the medication, without checking the BP. She is administering the medications for the BP, like regular medication. Again, patient will go to the hypotension. So the reason is, one thing is she is not known about that medication. The second thing is she will be in rush. She will be in the busy schedule. And third thing is there is no proper training. There is no proper training on that. Is if someone is coming and joining, the nurse, the senior nurse or the senior should tell them this is the way we are giving the medications here. If you are giving a BP medications or hypertensive medications, you have to check the BP prior giving medications. Or if you are giving a medication for the sugar, or you are giving to the insulin, regular insulin also giving an IP patient, before giving you should check the RBS of the patient. So this kind of training should be there. Lack of training can be can be a cause, or lack of knowledge can be a cause, or the manpower can be a cause. So we have to identify what is the problem, why it is happening. We should not, so according to that cause, we can take an action. Prevention we can take it. So accurate patient counseling. This is also one of the responsibility of healthcare professional, that is either can be done by the doctor or by the pharmacist or by the nurses. Accurate and effective patient counseling is a fundamental responsibility. It is a pharmacist's chance to ensure the patient fully understand their medication regimen. This goes beyond simply reading the label. It involves explaining the purpose of medication, how to take it correctly, and what potential side effects to look out for. The use of plain, non-technical language and the take back method are essential tool to confirm the patient is understanding, improve adherence. This is actually it's a uh, main responsibility of a healthcare professional. So while discharging, it can be done by the nurses. Where the nurses are doing is, whenever the patient is getting discharged from the IP area, the discharge medicines will be explained by the nurses only. So she should explain what this medication at what time you have to take, when you have to take, and if antibiotics and all there, she should explain that with milk you should not take. If food and again food and drug contraindication she has to explain. Then is, if for example she is giving a warfarin to the patient, so for a what kind of warfarin to the patients, like post cardiac surgery patients, she's explaining this is a this helps to prevent the stuck of your valve. Your blood will be thin after you during taking of this medication. So the contraindication will be the bleeding. So overdosage of warfarin is bleeding from the mouth, gums or nose, whatever it is. So she has to explain this medication. After taking of this medication, if you feel any bleeding from any orifices, then immediately you have to come and meet the doctor. So this kind of proper education should be done by the healthcare professional to the patient, so that we can prevent so many contraindications and so many side effects and side effects for the patients, potential side effects to the patient. So how we can identify that patient is understood? The use of non-technical language and the take back method are essential tool. Take back method is, so you ask the patient to tell it back. Whatever you are telling to the patient, whatever you are counseling to the patient, just ask them to talk it back, so they can you can understand whether they understood or not. So collaborative care and unfeigned fraud. So modern healthcare operates as a team support. The collaborative care is key to achieving optimal patient outcomes. Pharmacists must work seamlessly with physicians, nurses, and other providers. This includes communicating new drug information, clarifying prescriptions, providing drug therapy recommendations, and participating the patient rounds. As I told you earlier, the multidisciplinary team is including the pharmacist also. The clinical pharmacist is reaching to the patient every day, every basis, every morning, and then they have to clarify the prescription, drug information, and if the nurses or other technicians or anyone is having any doubt or anything on the medication, the clinical pharmacist will be giving the clarification regarding that. Then they will provide the recommendations. Even to the doctors also, they are giving the recommendations that doctor, you cannot prescribe this antibiotic to these patients because the patient is having this kind of contraindication. If she has taken this medication, she will be getting another complication. So if the clinical pharmacist have that right to stop them. Okay. So effective collaboration with the healthcare professionals like nurses, physicians, and all providers, even the technicians also. So it will lead to the better and safe care. Anyway, we all as a team, we are working to give the self care and better, safer and better care for the patient. Our ultimate goal is to give a safer care for the patient only. So monitoring patient outcomes, the ongoing commitment to the patient well-being. So pharmacist role does not end when the medication is dispensed. Monitoring patient outcome is an essential ongoing responsibility. This involves tracking clinical endpoints such as blood pressure or blood sugar levels, as well as subjective patient reports of symptoms and side effects. By engaging this therapeutic drug monitoring and regular follow-ups, pharmacists can identify the address problems clearly, so they can the new batch or a new manufacturing drug came and they are dispensing to the IP areas or to the patients. So they have to monitoring how outcome is coming. With this medication, patient is getting better or getting worsen. That is also a responsibility of a pharmacist. Thorough documentation, a clear, accurate and legal record of care. So documentation is a bedrock of professional accountability and community of care. Every action, decision or communication related to medication management must be meticulously recorded. This includes a clear record of a prescription, any intervention made, all patient counseling provided, and communication with other healthcare providers. Accurate and timely documentation serves a legal record justifying billing and ensuring seamless transition of care. Final thought, remember that every medication, every interaction and every procedure ultimately impacts the person life, the patient behind the prescription. If someone, family member, friend or neighbor, your dedication, compassion and expertise are what transform a collection of chemical compounds into the treatment that heals and improves lives. So never lose sight of human element at the center of your work. Thank you, all of you. Hope you all understood this.
Yes, ma'am. Thank you for such an insightful. Now I invite Mr. Prakasham to moderate the interactive Q&A session.
Thank you, ma'am. Thank you for your presentation. So there are some few questions for asking chat. May I ask one by one?
Yes.
Yeah, thank you. From your perspective, what are the most critical responsibilities of an ICU nurse, and how do you these responsibilities differ from those nurses in general wards?
Yes. So usually in general wards, they don't have the narcotic drugs and lookalikes or high alert drugs. And they will not get any like code blue patients, or they will not have any critical care patients. So this narcotic is very, very important for a ICU nurse. So whenever we are, as I told you earlier, narcotic policy, we have a separate narcotic policy according to act that a general nurse, she cannot able to handle the narcotic drugs. They don't have the license for that handling the narcotic drugs, and they will not have the floor stock also. The general wards, they will not have the floor stocks. The maintaining of floor stock of medication is also a part of ICU nurse duty also only. And critical care, handling of critical care patients, the ventilator patient, we are handling the patients like ventilator patients, all trauma patients. So one hand we will be with the patients, and one hand we will be with these kind of medications or with the equipments, all equipments. In general ward, we will not have any equipments like infusion pumps or ventilators, feeding pumps, nothing will be there. Only the thing is, patient will be admitted, and as per the doctor's order, they will give the medications. But documentation will be again same only, but they will not have any critical things like handling of equipments, medications, and the critical patient at the same time. That's a different. and the care will be the individual.
Yeah, thank you. The next one, what are the roles of clinical pharmacists in managing the medication usage while any ADR or side effect has been identified?
Okay, again, clinical pharmacist in nowadays in the most of the hospital, we are multidisciplinary team is coming. So ADR and side effect, if any ADR is found by the nurses, immediately they will inform to the pharmacist. So we have a separate, immediately they will stop the medications, and they first they will inform the doctor on duty. So we have the doctors 24/7 in the ICUs. So we will inform them. So according to that ADR, they will prescribe some antihistamines or they will prescribe some antidotes of medications. Then after that, the adverse reaction form will be sending to the pharmacy. So this pharmacist will be discussed with the doctors, and ADR for there will be a like a committee is there for the ADR adverse reaction effect. So according to that, they will find out what was the problem, why it happened. Maybe because of because this patient maybe might have taken the same medication earlier, but that time the patient was have not so the patient was not having any side adverse reaction, but this time it happened. So second time, well, I had an experience same like that. So I have given the levofloxacin injection for a patient in the first day. Patient didn't have any of the like or any reaction or anything. Patient was very well. She was having she didn't have any problem. But after 2-3 days, again the same patient was my location, and I gave the same medication, but the brand, the manufacturer was separate, the different manufacturer. But after giving that medication, the patient developed full of itching and rashes. So this is an example. So the clinical pharmacist can review why it happened. So according to that, they will take. Maybe that manufacturer they will stop, or they will report to the manufacturer company. So they will be they are playing that kind of role in the clinical pharmacist.
Yeah, thank you, ma'am. Another one question. Are you practicing any e-prescription and telepharmacy in your hospital?
Yes, all prescription will be in the system only. We don't have any paper usage. We are using all prescription in the e-prescription only. So we will get we are using Insta. So we are getting the order in the system. So we will intend the medications. We will have the count there. So according to that, we will intend the medication. So once we intend in the pharmacy system, it will be reflected. So according to that, they will bill and they will give the medication again to us. Again, after giving this medication also, we are signing, not in the paper, we are signing in the system only. In which time to which time the infusion given, and we have the separate prescription method for start medication. Start medications will be reflected in the red color. So it will be dispensed by the pharmacist within 10 minutes, 10 to 15 minutes. If the doctor is prescribing the medication at 3 o'clock, and the nurse will intend by 3:10 or 3:15. By the 3:30, the medication will be given to the patient. So that is the protocol for the start medication. It will be reflected in the red color. And for the PRN, actually PRN nowadays we are not using, but in case if something is once order we are using, that will be reflected in the blue color. So that medication will be given to the 1 or 2 medications only will dispensed by the pharmacist, not more than that. And regular medication will be in the black only, that will dispensed within 24 hours. Actually, for the 24 hours, we are intending the medication for acute care patients. For the long-term care patients, they are intending the medication for 7 days. That will be in the black color. the pharmacy will get the reflection by these 3 colors. And for the control narcotic drugs, we are directly connected to the Ministry of Health. So whenever there will be the separate portal is there. So in that portal, doctor will prescribe, as well as in the hospital portal also. So both they have to prescribe the medications. So they will prescribe the medication in both portal. The narcotics, we have the stock in the ICU. So that according to the doctor order, we will prescribe. So without any prescription, we are not going to give, and even in the emergency situation, we will not give any medications. We have that right here in to stop them. So first they will give the order. So according to the order, we will go, 2 nurses will go to the narcotic cupboard, and they will open the medicine, they will administer. If there is any medication is left over, then we will discard the medication then and there in the running water, and documentation will be there. For this narcotic, we have 2 types of documentation. One is manual documentation, and the other one is this e-documentation. So in the government portal, that is NPCM, that is NPCM portal, that the 2 nurses has to sign. Again, the doctor order will be there, that according to the doctor order, the patient emerites ID, that same like Aadhaar card, no? So we are having the Aadhaar card in India. So same like patient emerites ID will be here. So that we have to, while prescribing itself, doctors will give that emerites ID number. It is already there in the system. Whenever the patient is getting admitted into the hospital, the emerites ID for all patients will be updated. Either emerites ID or the passport for the other country people. So it will be updated. That number we have to find out. Then according to that, we can find out the patient. For that patient, then doctor will prescribe the order. The nurse, after giving of injections, the nurses will, 2 nurses will be signed in this. First, initially from my ID, for all the staffs, the ministry is giving the separate ID and password. So from my ID, if I am giving a medication, I will sign and I will give the witness to the other person, the second RN who was with me, so that she can open from her ID and she can countersign it. So before countersign, she should confirm the batch number and the code of that medication. For every control, semi-control and narcotic, the ministry is giving a specific code to the hospital. So that code will be in the desktop, in each desktop of the ICU. So that code we have to give. The code is different. Again, the problem will happen. After signing, we have to we will find out the stock is correct or not. If actually I had a mistake that my patient was getting the tramadol injection. Here the tramadol injection also a controlled drug. So my patient was getting, actually we have 10 medication only. 10 medications in the floor stock, in the control medication. So usually here more than 50 mg, very rarely they will prescribe for the medication. But in India, as it is, we will give for everyone, it is 100 mg, 200 mg like that. But here more than 50 mg they will not prescribe. For my patient, he has prescribed 100 mg. For the clarification, again I checked, it was 100, but while I signing the medication, the prescription will be 1 ml or 2 ml. But that instead of keeping 1, I kept 100. That is 100 ml. So after signing, when I opened my system, the NPCM portal was -42. The ampule, this -42 ampule is showing in the system as a minus stock. That's then immediately I raised a ticket to the portal. So the ministry is, I have given the justification of about that. They said okay, but still the count is -42. The problem is in-house pharmacist cannot do anything. They have to, my ticket is closed. But the thing is, The count is showing again it is minus 42 only. They have to come. The ministry people will come to the pharmacy. They will take the pharmacist with us. They will come to the ICU. They will ask me what was the problem, how you have done this, what was your issue, everything they will ask me. Then they will go to the narcotic cupboard. They will open physically, they will count, and they will check the camera. They will check camera, how many ampules I taken, everything they will check, because this narcotic cupboard under surveillance of a CCTV. That is also connected to the Ministry of Health. So everything will be done. After that only they will restock the medications. The system will be clear. So this much process is going on. Anything else, sir?
Yeah, ma'am. Two more questions. Can I?
Yeah, sure.
Did you experience medication errors formally reported and tracked in your hospital, ma'am?
Actually, right now in our hospital, nothing is happening. But when I was working other hospitals, it happened. Medication errors. So medication is errors. Actually, medication errors is a KPI for our key performance indicator of our hospital. So we are every month we are monitoring it. So, but as of now, I don't think anything is happened. Yes, in my remembrance, nothing is there. Only thing was one. They are catching if the drug, if rich medications they are giving, they are dispensing along with the other medication, the same packet. That is also here dispensing error they are showing. But only one time they have given like that, but we didn't raise that. So we don't have any KPIs. I'm not hearing. Your mic is off, sir.
In your experience, could you share instance where communication gaps among the healthcare teams almost resulted in serious medication errors?
Medication errors. Yes. Again, when I was in India, when we received a patient from the theater, that was a post-CABG patient, the doctor asked to start dopamine injection for patient, but one of my colleague started dobutamine. So that was sound alike again. So after some times when we the same shift, we did not find out that mistake. So after the shift, the next shift comes, when they check the medications, the dopamine injection was the same as Florstock what it was previous, but the dobutamine was less. That time they found that instead of taking dopamine injection, and she has started dobutamine injection. That was one incident. And another one was when I started my career in Narayana, I have only one year experience. One of my colleague, she didn't know the difference between the paralyzing agent and the sedation. One of the patient was in the ventilator. She was very restless, not on the ventilator, after extubation. She was on ventilator, and after extubation, she was very restless. So during intubation time, we were giving both both paralyzing agent and sedative agents. So after extubation, she didn't know we should not give any paralyzing agent for the patients. She has given that after few minutes or 2-3 minutes, patient got respiratory arrest. Again, we wanted to intubate that patient. By God's grace, we could save the patient, but this was an incident happened when I started my career. Not with me, one of my colleagues.
Yeah. Thank you. Thank you for your answers and sharing your nice experience, ma'am. So now I take out to Mr. Balakrishnan. Thank you, ma'am.
Thank you.
Thank you, ma'am. Thank you, sir. Now it's my privilege to invite Professor Dr. M. Rangapriya, ma'am, Organizing Secretary, to deliver the vote. Please, ma'am.
Very good morning, all of you. It's indeed my great pleasure to thank Mrs. Srimol on this very distinguished platform. I should thank you very specially and personally, ma'am, for what you have done today. Actually, the session was not a simple lecture. I should state that you have taken us, all our students, participants, everyone, a virtual tour of the hospital where a patient comes gets inside the hospital, right from that stage till the patient is getting away from the hospital, that is discharged from the hospital and gets into the home. So my very special thanks that you have make it in a very wonderful manner, even though there was disturbance in the initial stage technically. You took the session very nicely. It was very enriching and commendable. That showed your experience and your dedication that you have gathered in your service as a ICU nurse, and very proud to be a part of the healthcare team. That was my feeling when you were talking about all your experiences, and you were giving all instances. What I have to tell is you have touched how to identify right from day one, the 5 R's, what we will be using for identifying the patient, that right drug, right time, right cost, and all these things. From that, you were touching about the medication reconciliation, medication errors, look-alike, sound-alike drugs, and how the patient counseling can enhance a medication adherence to the patient, and how a nurse and a pharmacist and a clinician, they will be intertwined in bringing about the therapy a great success, and how clinical pharmacy and a nurse can go in hand with the patient to improve their quality of life. And you were all telling about what are all the narcotic policies, the documentations that you follow throughout the global, and also it was quite very enriching that in your hospital you don't practice any physical prescriptions. Everything goes on with the telepharmacy and telemedicine. So that was a very nice thing to hear. Actually, what I'm feeling very great to have this session. I hope so the participants would also be having the same experience. As I told, it's not a simple term. It's real that you have taken us on a virtual tour of a patient's journey throughout the hospital and various instances of a patient in a hospital, and how the patient is taken care by the entire healthcare team, intertwining. So at this platform, I'm privileged to thank one and all who have gathered here, the eminent professors, participants, and delegates from various institutions, academia, industry, as well as hospital sectors. And great thanks to our today's speaker, Mrs. Srimol Gangadharan, for a very enhancing and enlightening speech and the session in a very simple manner, and very understanding, and very encouraging to the budding pharmacists who are all getting into their pace of a clinical pharmacist. Once again, on behalf of the entire management, the principal, organizing committee, and the organizing team, as well as the entire fraternity of Excel College of Pharmacy, I thank our distinguished speaker, Srimol Gangadharan. Thank you, ma'am, very much.
Welcome.
And thank you, one and all. Thank you.
Thank you, ma'am. We extend our heartfelt gratitude to our esteemed speaker, respected faculty members, dedicated participants, and the organizing team for making today's session a truly enriching and experience. The knowledge and perspective shared have not only deepened our understanding of effective medication management, but also inspired us to work collectively towards safer healthcare practices and better patient outcomes. The International Expert Talk series will resume tomorrow with more thought-provoking sessions and insightful sessions. Wishing you continued growth, success, and fulfilling professional journey. Have a wonderful day again. Thank you.
Okay, thank you. All the best for all of you. And once again, I thank all of you to call me as a speaker in this your journey. Once again, I also thank everyone who the organizers, participants, and everyone. Bye. Thank you. Take care.